Hi, gentlemen. So it is about the times. They are changing. This is from Bob Dylan. On the left, you see how we used to fly planes 100 years back. We had to look around. We had to see the landmarks. That's how I did spine surgery. But on the right, you see, it is all done with computers. And if we do not keep changing with the times, then we will be left behind. It was great to see some of those wonderful talks from the earlier speakers. So I'm talking about robotic assisted spine surgery. So we have now reaching 500 and counting. We have now a very long experience. And people always ask me, why do you need a robot? You were one of the first guys to start putting screws. And yes, I've been putting screws for well over 25 years. My technique has been primarily freehand, like that old pilot you saw on the left. I see all the landmarks and then I put them. But I have realized that we have issues with obese patients when we do revision surgery in severely deformed spines. And of course, I had a reluctance to adopt minimal invasive techniques because of radiation issues. And I didn't do MIS for a very, very long time. But that has changed since I started using the robot. Of course, I had used navigation, jigs, and I wasn't too happy about it. So this is what we were doing for a high-grade spondy. And I put it on LinkedIn, and then somebody got back, hey, what does it take to put a couple of screws? So I go back to my point. You do need it sometimes, and it is great to have this new tool. Now, you do come across surgeries. Here, you see a surgery done by a senior surgeon in our country for an Indian lady who works as a nurse in the NHS in the UK. She came back to have her spondy fixed. And you can see this is a disaster. She has never been able to get back. Her bladder is gone. She has big deficits in her feet. So she is a crippled person. So these kind of accidents can happen to all of us. So this is not the way to do spine surgery. We have been putting pedicle screws, and we know that the pedicle offers the strongest point. And they have been widely accepted as an invaluable part of spinal instrumentation. Lenke went on to say way back in 2004 that posterior spinal instrumentation using pedicle screws is the state of the art in deformity correction. It depends on your technique, how you put your screws, training, experience, and the resources available. Most of us use the freehand technique. Of course, some surgeons do it under direct fluoro guidance. We know that misplaced screws cause a lot of problems: dural tears, root injuries, paraplegia, vascular injury. Fortunately, these complications are rare. More important, misplaced screws have a predilection for not having good stability or good strength. And so it doesn't work very well if your screw is misplaced. Then comes the challenge of revision surgery. And in a fusion mass or a pseudarthrosis, it's extremely difficult to find the exact location of your entry points. So it becomes very difficult. So the conundrum is whether one uses freehand technique, intraoperative markers, radiographic control, or navigation, mini laminotomies. The number of malpositioned screws will continue to remain very high as long as we do not have the tools like the pilots have on the right side, which you saw in the beginning of the presentation. So it's all about making dangerous spine surgery safer and also reducing the hazards to the surgeon and the operating team. We were one of the earliest to start using the robot. Way back in 2012, we started with the Mazor Renaissance second generation robot, and we were quite happy with it. In fact, it was wonderful. It was virtual pedicle screw placement. So the day before, I would sit with a high resolution CT and plan my surgery and plan my screws and take it to the theater, and would be able to then, after doing the 3D syncing with the things that we used with the earlier generation robot, AP and 60-degree oblique X-rays were taken, and then we would mount the robot. That Coke can that you see on the top right is the way it would be kept. That is the robot, and that would there would be a mount for the robot, and then we would start robotic guided pedicle drilling. So when a patient with a severe deformity like this comes, and you know that these are sometimes challenging cases to do freehand, and you assess them, and then when you are able to guide all these screws robotically, it reduces the stress levels like nothing. And here you have the same lady on the left side before surgery and after surgery. She is doing well. Now you have this child coming with a far more severe deformity. You can see she has hemivertebrae at multiple levels. Her spine is displaced in space in all directions. Doing this type of surgery freehand would be an absolute nightmare. Besides the fact, as Dr. Kotari said, there are dysplastic pedicles, and you may not be aware of them unless you do a CT scan. Here you see a CT which shows the hemivertebrae and the severe deformity. So I do the virtual planning of the screws. I know which screws, the size of the screws, the length of the screws, and everything is planned. And here you see the directions with this old generation robot. I'm putting these screws in all directions. I'm putting the screws on the right side from the left. So these kind of trajectories are very difficult to get if you're doing freehand. This is one more view from the top. And then here you see how the drill guides and then the screw placement is done. And once you are able to put these screws, you do the correction, you do the hemivertebral excision, and you get an excellent correction. And this is how the girl looks after surgery. So you have a safe surgery. Here you have a child who comes to us from Gujarat. She was operated multiple times. Now the challenges in this very small child is not just that she has had multiple surgeries which have failed. She's a small child. The vertebrae are tiny, extremely small pedicles, total loss of landmarks. And this is how the child looks prior to surgery. You can see the scars of the previous surgeries. You can see here the broken implants. So as a first stage, we remove those implants and then get a high resolution CT. Here you see all the landmarks are completely lost, and it is very difficult to do these kind of cases, very dangerous, I would say, to do these cases if you have to do them freehand. And then you have very, very few options. So we guided with the robot, we were able to place with extreme precision all the implants and get a good correction, and she went on to do well. So what is new? We have now shifted to a new generation robot, and this is called the Excelsius, which we have been using for the last 3 years. It is much more user-friendly, and the robotic arm moves in all directions. It is floor-mounted, and this is most important for me. It is very rigid. You can hang from the robotic arm. That's how rigid it is, and it moves into perfect placement so that you can get your screw into the exact placement where you want. And these are all the standard parts of these robots. The integrated, all instruments are integrated for use with the robot. So that's when we started doing minimal invasive spine surgery with the robot. So if you have a classical case like the L1 burst, normal neurology, this patient comes in the morning and you do a CT spin before you take the patient for the surgery, high resolution CT, plan your screws, and then do it, take him for the surgery. By evening, he's ready to go home. So this is the minimal invasive surgery that we are able to do with this, with the robot. Here, I'm talking about a girl, 14-year-old who came with severe pain. She had the ancient disease, and by that I mean tuberculosis of the spine. She had extreme destruction of the lumbar vertebrae. The disease was spread, as you can see in the MRI, all over, front and back. She was just on the verge of developing a severe deficit. This is the CT scan, and this is what was planned. A robotic minimal invasive surgery, fixation, corpectomy, all done in the same. So here you see the patient is positioned in the lateral, and after the CT has been done, the fluoro machine comes in, takes the views, and then the robotic planning is done. And here you see the robot moving for putting the minimal invasive pedicle screws. And you do it in a precise manner. There is no possibility of going wrong. And you get the screws in place, you fit the rods in the same position. Of course, you do an anterior corpectomy, put in a cage, the good old-fashioned arms cage, and the child is doing very well. Here you come to a patient with a localized ankylosing spondylitis, affecting his upper thoracic and cervical spine, cervical kyphosis. He has very difficult problems day-to-day living because of the severe kyphosis, difficult to gaze forward unless he bends. This is how we had to do. So you can see here he has a very severe cervicothoracic kyphosis, as you can see in these x-rays, and the spine is fused. Now, if you had to do freehand, this would be a huge challenge to do the freehand instrumentation and to do the deformity correction. So here we do an intraoperative Zeem spin after the patient has been exposed. And this spin is fed into the robot, and with real-time information, we are able to place the screws. So you put the screws in different places and then do a correction at the C7 level. And here you see Dr. Apaji, who helped me to do a similar correction 20 years back. He is lifting the head of the patient for the correction before the instrumentation. And he has a good correction. That's how he looks on the right side. And of course, he is able to lead a normal life. This patient had what we call as global frontal and sagittal deformity. He had been previously operated for an L4-5 TLIF, which I had done. And he had this deformity and it was affecting the quality of life. If you see here all his preoperative alignments, including the lumbar lordosis, which is drastically reduced, and he is sagittally imbalanced. He also has compression at 2 levels. So the plan is anterior-posterior reconstruction of the deformity. So he is positioned here for the first stage, and we are putting through a small minimal invasive access the lateral cages at the upper levels. And once that is done, that is also helping to restore further the lordosis. Then the S2 ALR fixation, robotic guided. Now we all know that putting these screws in the ilium are sometimes extremely tricky. You know all the landmarks, but there are a lot of big vessels, and if you're in the wrong place, a disaster can happen. So the robotic assisted spine surgery helps improve the quality and in fact speeds up the entire surgery. It allows you to put these screws so quickly. Earlier we used to take a minimum 45 minutes to 1 hour for our iliosacral screws. Here we plan these screws just before we go in, and the screws are put within minutes, and you can see there, you see it exactly where it is going. So you get these screws in quickly. All the other screws are put within record time with the robot. We use femoral heads harvested from previous femoral neck fractures for our fusion. These are thoroughly morselized and used. And then, of course, the fixation is done. And he has returned back to his home country in Mauritius, and he is back to near normal activities. This is just a few weeks after his surgery. And finally, I want to talk about this lady who came with classical claudication symptoms. She was finding it difficult to walk. Her activities of daily living were severely restricted. She had degeneration in the spine, lumbar kyphosis. You can see the severe compression at multiple levels. So after you have assessed them, you do the pre-op data feeding and planning. Usually it is done by my team. And then an MIS multi-level robotic surgery is done. And we get a correction of the frontal as well as the sagittal deformity. She has got an excellent correction. As you can see here, her preoperative and the lateral postoperative. We usually make the patients walk the same day in the evening. So ours is one of the earliest robotic experiences. We have done now close to 500 cases. We have done over the last 3 years with the new generation system, and we are quite happy. I think in the future, we will be navigating cages. It's already happening. We will be navigating the degree of bend in the rods, in deformity. So all of this will be done through robots. And I think this is where spine surgery is headed. Thank you.